the most important, the few important menopausal issues which I would like to talk is, one of them is a vasomotor symptoms, and in 65% of postmenopausal suffer from this, whereas GSM 27 to 84%, and if you see osteoporosis by the age of 65 years, 80% of the women suffer with the osteoporosis. It's a very, thought-provoking incidents and the evidence. Sexual dysfunction, which we do not at all think, but it is also seen in 68 to 86%, and the sleep, of course, many of us feel up to 60%, this can be an issue. Now, just to show you the age group, when we see, if you see vasomotor symptoms, basically they start in mid-40s, go up to the mid-50s. But the neuropsychiatric symptoms, the GSM, the cardiac problems, cardiovascular disease, and osteoporosis, once they start, they keep on progressing unless and until taken care throughout the life. And if you see the GSM or atrophy problems, they usually start in mid-50s, whereas the osteoporosis, about which we will mainly talk, that starts in the early 60s. So these are the things which we will discuss. And now basically the all of us know the comprehensive healthcare which we have to give by the reassurance, education, and lifestyle managements, etc., which everybody has discussed. So I have to reach quickly to my main topic, and of course multidisciplinary team is required. There is a conventional treatment and there is a near-menopausal drugs. VMS symptoms basically, which are very important, and they do start in the mid-40s and go up to the mid-50s, whereas the other problems, once they start, they continue throughout the life. And if we see the atrophy of the urogenital system, these symptoms start in mid-50s, whereas the osteoporosis, osteopenia, they start in early 60s. So initially, of course, all of us know comprehensive healthcare system has to be seen in the form of reassurance, education, lifestyle management, which everybody has discussed. So let's go to the basic main treatment, and there we have two: conventional treatment or the newer menopausal drugs. So just to touch about, so that refresh, conventional treatment is basically the hormonal treatment, and which the most important indications are when the patients are or women are coming with the symptomatic hot flushes or night sweats, genitourinary symptoms, or women with the premature menopause till the average age. But most important thing to remember is MHT is not for primary or secondary prevention of coronary heart disease or dementia. That we have to remember. Now, why do we search for the newer drugs? Because you all know there are many limitations of the MHT, maybe acute liver disease, maybe active or recent VT, current past suspected breast cancers, hypersensitivity, or sometimes there are patients we are having undiagnosed genital bleeding or untreated hypertension or endometrial hyperplasia, where we cannot use the MHT. WHI has supported its use, but all of you know that it is not for more than 10 years after menopause. And even transdermal vaginal preparations also have to be used cautiously if we have to use later on. So that is the need to go search for newer drugs. Now we see the vasomotor symptoms. Most distressing part is there, and the commonest indication for MHT is there. Depends on the severity. Conventional, in the mild treatment, we all know moderate when the MHT is indicated. And if we talk about that when to give it, if the uterus is absent or present. If the hysterectomy has been done, there is no issue. Estrogen alone can be given for a long time. If the uterus is intact, then we have to worry for it, how to give it. We can give a combined estrogen progesterone therapies, or if the FMP is less than 12 months, that is the final menstrual period. And if the FMP is more than 12 months, then we have to give a little different one. So different preparations may be transdermal, different combinations of estrogen and progesterone in a different forms have to be given. And the most important one, which these days everybody prefers, is the transdermal or oral estrogen plus LNG levonorgestrel IUD. This is the most comfortable regime which is being preferred. But if the FMP is more than 12 months, then they can also use Tibolone or the oral estrogen plus SERMs. Now, there is one more point which should be very carefully looked for, and that is any increased risk of VT, stroke, or if the BMI is more than 30. If any of them these is present, then our approach in the regimes will be up towards the transdermal HRT. Whereas if nothing is there, then we can definitely go for oral preparations, which are cost effective and convenient also today. Well, these are the usual doses. I will not going into the detail. All of us know the oral estrogens, conjugated estradiol or esterified, or different progesterones, even dydrogesterone has recently been used more, or the combinations we can give it. Then there are some non-pharmacological things like phytoestrogen, black wash, cognitive behavior therapy. There are non-hormonal treatments, which are like SSRIs, SNRIs, and out of these, venlafaxine and desvenlafaxine. These are the two drugs which are most commonly used. Pregabalin is also very important, either given at night or twice daily. They do help in cases of the VMS patients a lot. Now, a newer drug, that is a third generation SERM, bejedoxifene, which binds to both alpha and beta receptors with a high affinity as agonist on skeletal tissues and as antagonist on breast and endometrial tissue. That is what the menopausal clinician probably wants, because that will have the danger to breast and endometrial tissue will not be there. Now, this tissue selective estrogen complex, that is CE plus B bezodoxifene combination, is the first FDA approved medication. And this is purposefully designed for those cases where skeletal and lipid parameters have to be improved at the same time, benefiting the hot flushes. Yet to be launched in India, that is the only important worrying thing. SMART-2 trial otherwise has shown that 80% reduction of hot flushes occur. So quite a good drug, and we are waiting for it. Tibolone, all of us know, it is a steroid, synthetic, related to 19-norgesterone, mildly estrogenic, mildly progesterogenic, mildly androgenic. Now, its effects on the tissue, like estrogenic effects are there on the brain, bone, and vagina. And there's an undesired effect of estrogenic on the endometrium and breast. So that is avoided. And that is what, again, beneficial for it. So only orally available drug, it is there, and it is approved for the treatment of moderate to severe dyspareunia. And significant score of hot flushes is reduced. And the most important thing, it is a therapy of choice when women who had endometriosis before menopause, or they have unwanted side effects with conventional MHT. So that's a very good drug, but of course you have to take care of it. Now, another very newer drug for VMS is, if you see NKB or neurokinin B or neurokinin 3R, these are signaling pathways. They play a key role in pathogenesis of hot flushes. So their antagonist, one of them are very known as MLE4901. It improves both day as well as night symptoms, and quite good within 3 days. And the symptom-free period is 4 weeks after stopping the treatment. So these drugs are newly coming and are very helpful. Now, the second most important issue is genitourinary syndrome of the menopause, which was initially labeled as a VVA. The principal components are 3: vaginal dryness, painful sex, burning, and dysuria. And they are usually progressive unless and until taken care. Now, first line and mild symptoms, non-hormonal treatments, I will not discuss. Moderate to severe symptoms, which are not responding to non-hormone therapies, there we have to discuss, and there we use local hormonal therapies for GSM and VVAR, local estrogen and also intravaginal progesterone, DHEA. Now, transdermal testosterone, etc., are off-label drugs. We don't actually, just to, I've written it, but there we don't use it. Vaginal cream, locally, we all know, 17-beta estradiol, conjugated estrogen, estrone, they are available and we are using it. Vaginal inserts are also available. And the new one is, I told you, progesterone DHEA insert. So that can be used again, vaginal ring or oral tablet. I'll talk in a minute. This vaginal dihydroprogesterone or progesterone, it is the steroid hormone and it is transformed by the vaginal mucosal cells to estrogen and testosterone, and that's how it works. The low dose has been approved in the treatment of moderate to severe dyspareunia in menopausal women. So this is a quite, hopefully we are waiting for it, should be a good drug for high risk. Ospemifene. Now this is the new SERM, an orally available product approved for the treatment of vaginal dryness and moderate to severe dyspareunia. This is doses around 60 milligram per daily, and the caution is that the behavior is like an estrogen containing product. So we have to take care that there should be increase in endometrial cancer or CVD. If any such risk is there, that has to be taken care. Breast cancer risk is decreased. Now, then there are the lasers, it's energy-based therapies like lasers, maybe CO2 laser, maybe YAG laser. So the main thing which they improve the vaginal health, they cause microtrauma, the collagen formation, angiogenesis, epithelial thickening, and the healthy vagina. But the important thing to remember is that they are not yet FDA approved, because short and long-term efficacy and safety studies are required more. So friends who are using it, please take care and do more studies. The third important issue, which is the thing, is osteoporosis, which is a chronic progressive health issue affecting large population of postmenopausal women. It has inverse correlation between number of years since menopause and BMD. Most common sites are hip, spine, and forearm. BMD has a strong independent predictive value of bone mass measurement. So the lower bone mass has been proved as a most important objective predictor for fracture risk also. Now what to do? The most important thing is prevention and then the treatment. So prevention, promoting, of course, healthy habits, nutrition, calcium, vitamin D, physical activity, avoidance of harmful habits like smoking, alcohol, all are important and we have to counsel them. But friends, remember one more important thing. None of these approaches can improve BMD. They don't improve the texture or the cortical or trabecular bone. So there comes the role of pharmacological therapy to prevent bone loss. And the conventional one, all of you know, various oral and transdermal estrogen preparations alone or with progesterone. Tibolone, these two I have talked. Then bejidoxifene, raloxifene, and bisphosphonate. These are the basically anti-remodeling drugs, and we'll talk about it. Hormones, I'll just tell you one thing. Basic use, I will again repeat, is for VMS or for GSM, but the secondary benefit is for the bone protection. This bone density protection, remember, it persists only till the therapy is continued. Then it abates on discontinuation. Extended use of HT is a very controversial thing, but it is an option for rare cases, well-counseled women, and when alternate therapies are not tolerated or the benefits outweigh the risk totally. Now, anti-remodeling drugs, I've told you, raloxifene and bejidoxifene. This raloxifene is a weak estrogen-like anti-resorptive property. Only EAA approved for the prevention and treatment of PMO. Good option for those women who have elevated risk of breast cancer or infrequent BMS, low risk of hip fracture, low risk of stroke or VTE. Now, bejidoxifene plus CE, which I have told you, a TSEC combination is the best candidate for this are the women with uterus for relief of VMS as well as preventing the bone loss. Now, the same precaution has to be taken as MHT, and I have told you the dose. Bejidoxifene has to give in 20 milligram plus conjugated estrogen 0.45 milligram. Remember, these are for young postmenopausal women, not after 60 or after 10 years. Now, the bisphosphonates, another most common remodeling drug, which binds to the bone matrix, gets absorbed into the osteoclast and at the site of active bone remodeling. It can be considered in women where the low BMD T score less than 1-5. I think we all must be in the same group, and or there are a family history of risk fractures. So this is a good drug for them. It is considered to prevent bone loss. When estrogen cannot be taken or relaxin is continued, there also it has a role. But the caution is, friends, that significantly impaired renal function is there. Please don't use it. Protection wanes slowly after 1 to 5 years. High risk in those women where the high risk factors is you can continue or shift to denosumab or osteoanabolic agents. The holiday is only considered for the low and moderate risk women. So basically, they are recommended as a first-line drug for PMO, and the rank order for binding affinity is zoledronate, followed by alendronate, ibandronate, and then risodronates. So these are the 4 bisphosphonates which are very good. Now, another newer drug is denosumab, which is a fully human monoclonal antibody. Inhibits the ranked ligand, which is the principal stimulator of bone resorption. So bone resorption is inhibited now. Appropriate for high risk of fracture. No limit of duration, 60 milligrams subcutaneously every 6 months. Effect wanes 1 to 2 years after stopping the treatment. So the basic thing is, remember, is once denosumab is stopped, bisphosphonate should be added to prevent the bone loss. Now, calcitonin, Salomon, these are nasal spray, basically mainly used for when there is a severe pain or the short mobilization is required. And the last newer drug, osteoanabolic therapies. Now, these are the bone building drugs. They stimulate bone formation and restore structure of trabecular bone. So result in larger and faster gains in BMD, should be followed by anti-remodeling drugs, which we have discussed, and the most appropriate for in women who have a very high risk of fracture or very low BMD. And the parathyroid, you all know, which is the receptor agonist, teriparatide and abaloparatide. They are the 2 important synthetic peptides. Teriparatide, this is very commonly used by the orthopedicians and significantly reduces the vertebral and non-vertebral fractures. But its earlier therapy used to be limited for 2 years. But in 2020, a guideline came that repeat course can also be taken. Abaloparatide, it is a further modified to potentiate the anabolic effect and reduces the risk of vertebral fracture by 86%. Especially increases the BMD of hip region, so it is very beneficial for them. And fracture prevention benefits are maintained for additional 2 years after stopping. And the next is romosozumab, that is humanized anti-sclerostin mononuclear antibody, which stimulates the bone formation while inhibiting resorption. Monthly 2 subcutaneous injections are given for 12 months, significantly reduces the fracture risk, but please remember that it is not recommended for the women who have a high risk of cardiovascular disease. So the existing treatment, to summarize, I can say, if the patient has an osteoporosis and no menopausal symptoms, then BPNs, denosumab, raloxifene, MHT, teriparatide, they are into your armamentarium. You can use any one of them depending on your role. If the patient has a menopausal symptoms, then you can also add the MHT will be the first drug, or the tibolone, and the other can be given. In case of the severe osteoporosis, MHT, tibolone, etc. will not work. Here, denosumab, teriparatide or calcitonin, of course followed by BPNs, will be the drug of choice. So friends, key messages are that the VMS, GSM and osteoporosis, these are the 3 major concerns in the postmenopausal women which need to be addressed. A comprehensive, holistic, multidisciplinary approach is the key element in the management of post-menopausal women. Lifestyle modifications, relaxation exercises, yoga, cognitive behavioral therapy are always recommended, and they have been discussed a lot. MHT is the main pharmacological treatment recommended in patients after ruling out contraindications. We have to be very careful. Many of the in fact, gynecologists still are afraid for using MHT, but they are a very good drug. Due to various limitations, sometimes intensive monitoring during treatment, newer molecules are being devised, and they may be recommended in the treatment plan in the near future. So I will hope that our postmenopausal women will not suffer and will go a long way forward. Have a happy journey of second evening. Thank you very much.